Our next questions are for the plastics men here. Can Botox help the wrinkles around the mouth, and what kind of creams do you recommend?
Yeah. Well, so there are many areas in plastic surgery where we're looking at solutions for many of the different manifestations of scleroderma. And so the question, though, for this particular topic is, how does the mouth, what kind of interventions can be done for the wrinkles that we see? And yes, the answer is Botox can help, but it's a very limited duration of therapy, maybe 4 to 6 months at the most. And it doesn't really get at the underlying problem, which is the fibrosis that one gets between the muscles and the skin that's around the mouth. And so with Dr. Wigley's blessing and help, we have actually looked into the use of fat transfer to the mouth area. So this would involve your lips, your cheeks, your chin, to try to restore some of that lost volume, but also, and we can get into this later if you're interested, we think that actually breaking up those fibrosis bands between the skin and the muscle is what really helps to take away some of these wrinkles, because the wrinkles are a secondary side effect. So yes, Botox does work. I'm not aware of any creams that can be applied topically except for maybe good skincare. And you want to be very careful with what you do in terms of how aggressive. There are many different treatments for facial rejuvenation of your skin. I would be cautious about a lot of those, such as chemical peels or dermabrasion. Those might actually have the effect of causing more scarring than less. So we're hoping that this new idea about transferring fat with stem cells may be a way to deal with this problem. And
I don't really have anything to add.
well, except Dr. Leach is an expert in Botox in scleroderma. In a different area of the body.
That is true, but it's actually Botox for the hand that's more related to the Raynaud's, the blood vessel spasms. We did a randomized study here, when we finished about 3 years ago, give or take, which we learned a lot about it. Unfortunately, it is still considered an off-label use for Botox in the hand. But the idea is by a different receptor than the one that it uses to weaken muscles that make wrinkles in the face, we think that it diminishes the spasticity of the blood vessels in the hand. We've had some promising results, especially for patients with relatively less duration scleroderma, which in our study, relatively less duration just meant less than 15 years, and patients who are responding to agents like mifepristone and lodipine Revatio. All of these are indicators that the blood vessel spasm may be more spastic rather than fibrotic. The Botox does seem to be more effective for them. The downside is, and this may relate to what you may or may not be able to do to help with us, it's still off-label, and so getting insurance coverage for it can prove to be very challenging. I've read letters from many patients, about 1 in 10 gets approved. Some patients choose to pay for it out of pocket, which compared to some treatments, it's not horribly expensive, but that is one downside, is it's considered an off-label use, and oftentimes it isn't covered by insurance.
Dr. Lipshay, we still have another question for you. How many times can one be operated on their fingers?
It's a good question, and I don't know that there's a number that is the answer, because there are a lot of different circumstances in which we operate on the fingers. There are 3 main groups of types of surgeries that we do for scleroderma. One is blood flow surgeries, either stripping the scar tissue from around the arteries or sometimes even doing bypasses of the arteries. That tends to be more of on the near side of the hand where the vessels are a little bit larger. There are surgeries to remove the calcinosis. Now, not all scleroderma patients get calcinosis, but for those of you who do, there can be chronic wounds associated with that, or just pain associated with the mass of the calcinosis. There are surgeries that we do to just remove or debulk the calcinosis. And then finally, there are surgeries for contractures. For some patients, their fingers get very much stuck down in a flexed position, plus or minus ulcers on the back of the fingers because the skin gets stretched too tight. So depending on an individual patient, any number of those surgeries might be appropriate. The calcinosis removals tend to be the least invasive, but also the least curative, meaning we can do those repeatedly, but they just improve it. They don't fully cure the calcinosis, but if the calcinosis is bad enough, that can be a very meaningful improvement. On the other end of the spectrum, the contracture surgeries tend to be very durable, but we tend to save those for more advanced stage disease where there really isn't a mobility solution to get the fingers out of the palm, and we end up fusing the knuckles in a more extended position. And then the blood vessel surgeries are somewhere in between, where we can repeat them usually in a different spot along the blood vessel. So the short answer is there's not a number, and it really depends on the specifics of what is the reason that we would be doing the hand surgery.
Thank you. Our next question is for Dr. Matai. What is pulmonary hypertension, and why do I need a PFT and echo every year?
Glad I got the easy one.
In 30 seconds.
So pulmonary hypertension is a complication that occurs in anywhere from 10 to 15% of patients with scleroderma. And it is a disease that is characterized by elevations of pressures in the lungs. And the pressure elevation can occur whether or not you have regular high blood pressure or systemic hypertension. It doesn't really have any relation to whatever your blood pressure is. You can have high blood pressure in your lungs without having systemic hypertension. So one of the concerns we have about this is that when you have pulmonary hypertension, it's important to identify whether it's present or not, and then to treat it if we can. And there's some caveats about treatment which we can talk about later. But it's important to identify whether or not you have pulmonary hypertension. Hence, the yearly PFTs and echocardiogram and perhaps some blood work as well can help us decide whether or not it appears as if pulmonary hypertension might be developing. So when we look at your pulmonary function tests, we're looking at not only changes in your lung function as assessed by your lung volumes and how much air you can blow out in a second, but also particularly the measurement of what's known as the diffusing capacity, or the DLCO. And that measurement tells us how easy it is for oxygen to get from the air into your bloodstream. And if that number is declining, then sometimes that suggests that there's a problem with the blood vessels in the lungs, which is where the predominant problem is in pulmonary hypertension. So the echocardiogram is also helpful to let us know if there are elevations in the pressures, but the echocardiogram unfortunately is not sensitive enough to tell us whether or not you actually have pulmonary hypertension. So one of the things that can be confusing is when you have an echocardiogram and the report comes back and says, oh, you have pulmonary hypertension. It's not actually that accurate of a test to tell us whether or not you have pulmonary hypertension. So I caution you when you see reports or talk with your doctors, the real definitive test, unfortunately, is more of an invasive study, and that's called a right heart catheterization. So anyone in the audience have a right heart catheterization? Yeah, so on a scale of 1 to 10, how bad is it? Okay. So it sounds scary, but a right heart catheterization actually is usually pretty well tolerated by patients. And what it involves is we typically go through the blood vessel in your neck, we numb up the skin, we put an IV in that neck, and through that IV we thread a catheter that has a probe in it at the end of it into the inside of your heart, and we measure the pressures inside your heart, and then we measure the pressures inside the blood vessels that connect your heart to your lungs. And with that, we can understand whether or not you actually have pulmonary hypertension, and what degree of severity it is, and what are the potential contributors. Is it a problem just with the blood vessels in the lungs? Is it a problem with the left side of the heart? Is it a combination of those things? So it's very important for us to properly characterize what's going on in your lungs and your heart to have the right heart catheterization. So I think that captures that.
Thank you. Our next question is an insurance question for Tina. Can you tell me what a prior authorization is and why I need one for testing when I didn't need it in the past?
So prior authorization is just an approval from your insurance company approving the services that are to be rendered. Why one would be required now, since we haven't had to have one for years. One of the main goals of a lot of the insurance companies, well, most of the insurance companies, is to save money. So, of course, the inconvenience of the patient, but the authorization is to make absolutely sure that the patient has to have the services done, and especially in this setting, our outpatient hospital setting, where services are rendered by physicians in an outpatient hospital, as opposed to a private, doctor's office, the costs are a lot more expensive to have the services done here than at a physician's office, what we call a freestanding physician's office. So we've seen in the last few years a lot of insurances that are now implementing a lot more restrictions on the services that can be provided without authorizations. So, of course, like I said, it's the goal is to save money for the insurance company, but it's a huge administrative burden for our staff to have to get the authorizations, get pushback from the companies. We have to send in clinical notes. So it's a very lengthy and can be stressful process for us as well. But yeah, if it's services that are medically necessary, then of course, oftentimes the insurance companies, they do look at that. They match it with their criteria in terms of what would be allowed or what would be approved. So yeah, I think that's it.
Thank you. Dr. Lehrman, next question is, what is cognitive behavioral therapy, and can this help me with my scleroderma?
Yeah, so cognitive behavioral therapy is a short-term intervention, so it's talk therapy, so no medication, usually between 8 to 12 sessions, where we focus on helping with adjustment to different emotions that people have related to pain, to depression, and it has two major components. So the cognitive part is changing the thoughts that you have that are related to your disease, to the things that are happening in your life, because we see that thoughts really do shape how we feel about things. They shape our emotions. And the second component is changing our behaviors or activities. Because many times when you experience pain or difficulty sleeping or limitations in function, that can also reduce the things that you do in your life that are enjoyable or things that you used to do that you found meaningful. So combining changing the way you think about your life in addition to what you do in your life can help you feel better, improve quality of life, reduce depression, improve pain, improve sleep. So definitely can help with the adjustment piece of scleroderma. There are also some studies that have specifically tested the effectiveness of cognitive behavioral therapy in individuals with scleroderma and have found that they're effective in reducing depression and anxiety and in general improving quality of life.
Thank you. We were going to see if anyone in the audience had a question. We should just stick with the... Yes, Mr. Boyd.
Dr. Bichet,
Yes, sir.
is there any anything we can do to increase flexibility outside of surgery in the hand?
Great question, and for what it's worth, surgery has limited ability to directly improve flexibility. It can change joint position. It's not as good as at improving flexibility most of the time. Specifically, we're talking most commonly about the middle knuckle, what we call the proximal interphalangeal joint. For other forms of arthritis and joint contractures, there are a number of options of what we can do, both soft tissue and then actual implants we can put in a joint that are less practical to do in a patient with scleroderma. The challenge we run into with doing surgeries on patients with scleroderma is the skin envelope. The ability to close the skin over whatever we do underneath can be very challenging. And whether it's on a finger, on a hip, or anywhere else, if you're going to put a permanent implant in the body, one of the requirements is you've got to be able to seal the soft tissue envelope over it. So a lot of the options that other patients with joint contractures have aren't as good for patients with scleroderma. There are some other examples where we can do things that are useful. So for example, if calcinosis is causing a finger to have a contracture, there's some value we can do with surgery. Getting back to your question of what are things that aren't surgery that can try to improve or at least slow down the loss of mobility, they actually get back to more of the day-to-day care of hands that are useful to do. So whether it's good hygiene for finger ulcers, whether it's maintaining a warm environment, whether it's regulating spasticity with medications like nifedipine and lodipine, sildenafil, things like that. We don't think of them as directly ways to keep the fingers more mobile, but in a lot of ways, they're the most direct and the most useful things that we can do in the sense that they can prevent the loss in the first place. It gets harder once the loss of mobility happens. Did that answer the question reasonably well? Okay. Sorry about that.
Thank you, Dr. Lucia. And I think we had a question.
Well, I think it's also fair to say that if you don't use a muscle, it tends to get weaker. And so hand exercises are important. You know, and so we tend to, in scleroderma, the hand tends to go in this direction. And so you want to do exercises that counterplay that, such as just stretching the hand, you know, and just gentle stretching can make a difference. And the little muscles that are in the hand shrink when you don't use them. So having a soft ball that you know, exercise the hand will strengthen the hand and prevent some of that loss of function over time. So use it or lose it.
Regarding the plastic surgery department, the past year, as I'm getting older, I've been having extensive dental work done in my mouth. And my dentist is somewhat frustrated because he cannot work the way he should work. So what you were saying earlier, as far as perhaps doing something to help out with patients, have you done this to help with dental work being done in patients with scleroderma?
Yeah, if I can repeat your question for everybody. The surgery that we're now proposing and doing for what we call microstomia or perioral fibrosis, that is the decrease in the size of your mouth, can this allow you to do things like dental work? I think the answer is yes. Yeah, I just did a quick literature search this morning on this procedure, and there were perhaps 10 articles, all of which were from all over the world, and no one has a very large series, and I think we've done about 10 of these cases, at least myself here at Johns Hopkins. And so what I have learned from patients is that, number one, they tell me that definitely they can open up their mouth more after this procedure. There is actually a scale that is used, which I have not done, but with any good research trial, we should probably be measuring this. And the articles from around the world, Iran, London, do indicate that the mouth opening is a little bit better afterwards. And then the proof is really can patients go and get things done. And so I think I saw a couple of patients this week who were either going to the dentist soon or had been to the dentist to get dental work done after their surgery. And it's very similar to my burn patients who'd also develop small openings for their mouths. What's interesting is that for burn patients, I often have to make cuts and incisions and literally open up the mouth more, but for the scleroderma patients, that doesn't appear to be the case. We can use the normal tissues or the tissues that have become abnormal and give them some flexibility and pliability that they did not have before. What we don't know is how long this will help keep your mouths, you know, as wide open as they need to be to eat and do oral hygiene and do dentistry. And so that's something that we're just going to have to follow our patients long-term for. But it is very exciting.
Can you describe exactly how it is?
Yeah, so sure, I'm happy to get into the technical aspects of this. So let me just take you back and tell you a little bit of a story that goes back maybe 10 or 15 years. In the aesthetic part of plastic surgery, we learned, you know, a decade or two ago how to take fat from one area of the body and put it somewhere else. And so it became very popular to get injections in your face and other parts of the body and also your lips. And so there are artificial fillers that can be used for this that add volume, but they don't appear to last very long, and they don't appear to change a disease process. So in my own specialty of burn reconstruction, I began to do fat grafting for burn patients because of their stiffness and their fibrosis about 10 years ago. And I was delighted because not only could I restore the volume, but the fat appeared to take very well, despite being in a scarred environment. You know, you've got a skin graft on top and burn scars below, and so when our basic science colleagues looked at this, they actually found that stem cells that are in your fat reserves may be responsible for this good take of these tissues. And in fact, burn scars, radiation scars, other types of traumatic scars tend to get a lot better after the fat graft. The color of the skin improves, the pliability or distension. And so it wasn't that much of a step to take to say, hey, what about scleroderma patients? Could this also be a good treatment plan? And in fact, there are now recognized codes for the procedure. So the government recognizes it. Now, we may not always get paid for it, but or it has to be pre-authorized, but at least it's on the radar of our insurance plans. And that's another issue that I can just mention, in that the procedures have all been covered so far. We haven't had any problems. Now, I didn't answer your question. How do we do it? So it's a pretty minimally invasive procedure. And even though I've only done about 10 or 12 patients, I can't speak for a larger series, but we've had no complications. So we do a little bit of liposuction. Typically, I'll make a very small incision in your belly button. I need about, ultimately, 20 cc's of fat that gets transferred up to your face. But we do a lot of work with the fat while we're harvesting it. So I may take out about 60 or 80 cc's of fat, which isn't much, for those of you who are hoping to lose. That's always the question. But we can talk later about that part. So that fat then gets washed and purified, and there are a number of ways that you can do that. I have my own way that I like to do it. I use a self-contained system in the operating room, so your fat never actually gets exposed to air. It never gets outside of a sterile environment. We don't add any unusual or any growth factors or compounds to it or any drugs. But we do purify it, we wash it, and we use the area of the fat that's very rich in stem cells. This then gets injected. So take that out of the belly. If we're doing just the lips, I make a very small poke hole on the corner of the mouth on each side. And by the way, you're asleep for this. So we've tried this under local anesthesia a couple of times, and patients do feel it. It's fairly painful because the skin is really adherent to the muscles of your mouth. And so it's just not that easy to get a needle in between those two structures without much pain. And so we do it under anesthesia, and we have special needles that are blunt that actually take down the little scar connections between your skin and your muscles of your mouth and the mucosa on your lips. And as I'm pushing this needle back and forth, I'm also injecting a little bit of fat each time. And so you do end up with several things that happen. One is the volume that you've lost in your upper lip or your lower lip does get restored. We overcorrect a little bit so that we know that some of the fat will get absorbed. Secondly, we're breaking up all these scar tissue bands, and I think that's the real help. And then third, the stem cells that are there probably are affecting your natural fibrosis process. So there are a lot of things that may be at play. And then because we're in that region at the corner of the mouth, I can also get down into your chin through the same poke hole and restore fat back into the chin. Some people get a lot of wrinkles on their chin. And then also we can go all the way up along the side of the nose and put fat there. A couple of patients with the dermatomyositis really have lost almost all their fat in their face. And so that requires a little different approach. We use a larger volume of fat, and we come in from the sides and inject the fat into the cheeks. So I've seen this overall field of fat transfer change so much over the last 20, 30 years. We used to actually take fat on its blood supply from elsewhere in the body and put it in the face to restore missing tissue. That would be microsurgery. It would take up to 6, 8, 10 hours to do the operation. Now we're doing little small operations. In fact, I don't even put a stitch in these incisions in the mouth anymore. It's so small, we're able to get that cannula in, and there's really no room for a stitch when we're finished. So we're very excited about it because just like in my burn patients, we now have something we can offer that wasn't present just a few years ago.
Thank you, Dr. Lotion. I'm sorry, Dr. Boltman.
We have an expert here. Can I lean on you a little bit? And can you, from the perspective of a dentist, this is Dr. Hopkins, Could you, from the perspective of dentist, tell us what the challenges are? And
I would say the challenges are reaching and treating the patient before the disease takes hold and before you have to do some of the surgical expansions that you were describing. And also dealing with significant dental problems before autoimmune treatment is started. Often getting in to start treatment and improve the health of the mouth can be quite challenging depending on the timing of when treatment begins. Once patients already had the condition for years, then we're dealing with basically the same things that you were discussing and trying to have room enough to get in and do the dentistry that we need to do, and sometimes it's very challenging to do anything positive. So yeah, it's that
Thank
I
you.
would say it's a challenge.
We're gonna go back to our paper questions and then we'll come back to the audience. We'll take the audience question now, okay?
I just was, could you repeat the name of this procedure, or spell it, the name of the procedure, and also can it be repeated?
Yes, so the two questions are, what do we call this procedure? We're still figuring that out. I code it though as two things. One is, and this is understood by the insurance companies, incisional release of perioral fibrosis. That's number one. And number two would be fat transfer or fat grafting to the lips. Or there are different terms for that. Can it be repeated? The answer is yes. I've only done that twice in patients here. For burn patients, I had no idea how well the fat would take. So we set everybody up for 2 sessions, and I stopped doing 2 sessions a few years ago because the first session was successful. And so, but I will tell you, in the cases that I've done, the 2, it was a little bit harder to do the second time around. The fat was a little bit thicker than I would have expected, because the second time we're putting fat into fat that's already been transferred. So I think there's not enough experience to let people know, but certainly for dermatomyositis, where you're losing large volumes of fat, I think you will need to have a couple of sessions, and we will need to go back to add additional volume. And the question is, what is the right timing for that? I don't know the answer.
Okay, our next question is for Dr. Hummers.
Hi.
Oh,
Do we know why we lose so much fat?
Well, I'll have to defer to our specialists in metabolism, so let me go to Dr. Whitaker.
no. No, it is, however, it is a uniform finding that when there is inflammation that is triggering scar tissue in the skin, that under that, the fat disappears. And in fact, when we see that inflammation resolve, when we see people going into remission, one of the things that we see is not only hair growth and recurrent return of oils to the skin, we also see the fat return. So there's we think there's an interaction between inflammation and the chemistry of fat cells, and those fat cells have hormones that regulate how small and big they are, and those are influenced by inflammation. So I think that's the reason, but it's uniform that in fact, there is some drug that interferes with, that's used in diabetes, that's used for regulate fat, that has some effect on fibrosis or scarring. It's been studied in scleroderma.
I just have one question, and is there a difference between if you have this procedure with your mouth done at an early time in scleroderma or a later time in scleroderma?
Well, that gets to a question I was going to actually ask the panel. And that was, what about the timing of these surgical procedures, whether it's a hand procedure, a fat transfer procedure? I would think that there's got to be sort of a sweet spot where you don't want to wait too long, but you also want to do it early enough to make it, and you want to wait until you're actually having symptoms. And I struggle with that because I do see a wide range of patients. I think that anybody who's symptomatic and can't open up their mouth to eat or to get their dental work done, that's a good enough reason to go ahead and start. It's going to be hard thing to say that if you don't have symptoms, we should operate on you. That's sort of a principle that we try to follow in surgery. But I would like to ask the panel a related question, and that is, when patients present to us and they're on different levels of medication, how concerned should we be as surgeons? So if they're on steroids, or I was going to ask about blood thinners, separate and distinct, also the autoimmune or the immune drugs, when should we as surgeons become concerned about wound healing possibilities? Is that a fair question?
Sure, that's me. Those are all great questions. In terms of the duration issue, some of these things, like the changes that we see around the mouth, do tend to be later manifestations of disease. So we are often in a position when we're doing this surgery, potentially later on in the disease. But I'm not sure that I don't think we know enough yet to know if there's a magical window. And then in terms of the other issues with medications, we have a lot of patients who take immune suppressing medicines, and anytime anybody's taking an immune suppressing medicine and is having an elective procedure, we definitely need to go through a thought process of, how invasive is the procedure, what is the risk for infection, and should we temporarily hold those medicines around the time of a surgery to make sure that somebody heals okay and doesn't get infection. So sometimes if we think there is risk for infection procedure, we will temporarily hold immune suppressive medicines depending on which medicine, for a period of time before the surgery, and we will let them resume the medicine again once we're sure that they've healed and there hasn't been an infection right in that immediate postoperative period. That's not so much based on data, that's just based on what we think might be the right approach. And again, it kind of depends a little bit on the type of surgery. This is a pretty minimally invasive surgery, and I think the risks, Dr. Holtman will tell you, are pretty small. So depending on what you're on medicines for, we might opt for a procedure that we think is very low risk to just keep people on their medicines. So that would have to be a discussion of which medicine you're taking and what the procedure is to kind of know that for sure.
So to add to what Dr. Hummer said, for hand surgery, probably the closest thing where we have this discussion about are for my patients with rheumatoid arthritis who tend to be on a lot of immune suppressive medication, some of which can be very strong, like the antibody medications like Enbrel and Humira and that sort of thing. Those two specific medicines are a little bit less common in the scleroderma population, but many patients are on steroids to some degree, mycophenolate or Cellcept to some degree. From the rheumatoid literature, there's actually good evidence that mycophenolate and steroids up to somewhere between 5 and 10 milligrams a day probably are okay to continue. There's a lot of mixed data about the antibodies, again, like Humira and Enbrel and that sort of thing. For my rheumatoid patients, I do typically stop those for a month. There's the added issue of rheumatoid patients don't typically have the fibrosis of skin the way that scleroderma patients do, so should we be more cautious and be a little bit more liberal in holding the medicines? I agree with Dr. Hummers, it's sort of a person-by-person discussion. What are the risks? What is the size of the incision that we plan to make versus what are the consequences to the rest of your body if we say, we're gonna deprive you of this medicine that seems to be working for a week, 2 weeks, 4 weeks. But that's something that we're starting to study, but there isn't a good algorithm yet.
May I ask one more question then of us? And that is anticoagulants. And there are different degrees of thinning out your blood, ranging from aspirin all the way up to Plavix and beyond. And so again, as surgeons, we struggle. We don't want to create bleeding or hematomas for many reasons. It can cause infection, it can destroy your graft, it can cause weak wound breakdown. And so my own approach has been, if someone's on aspirin, that's okay. If they are on one of the more powerful anticoagulants like Coumadin, warfarin, or Plavix, I'd like them to stop that about a week before. And certainly if they're on multiple drugs, then I don't think we should do the surgery. And so my question to everybody, is it okay to stop these agents for a week beforehand? I think we're okay with starting them up very quickly after surgery. There are some patients who just can't go off their medications. They will get blood clots. And so that's a pretty easy call. But what about for the person who is on, let's say, low-dose warfarin, and we're trying to figure out if we should stop that? Or do you want to?
Happily, our patients often are not anticoagulated because of some of the complications we have in scleroderma with, for example, GI bleeding. So it's not as common an issue, but the answer is, again, depends on the risk and the reason that the person is on the anticoagulation. In general, we're able to stop for short periods of time through periods of surgery in a variety of settings without difficulty.
And
The
it should
state
be,
might want to say something in terms of pulmonary vascular.
and it should be said also, when you do go to surgery, you will have other interventions to prevent blood clots. So it's not like you're without any protection. We use the mechanical compression devices to keep the blood pumping.
So from a pulmonary vascular perspective, so blood vessels in the lungs, previously up until about a couple of years ago, it was recommended that patients who have pulmonary hypertension, any form of pulmonary hypertension, they should be on anticoagulation at a lower goal than you would do for other disease states, but essentially you needed to be on some form of anticoagulation with warfarin. That recommendation has changed, particularly and specifically for scleroderma patients, where it's recommended they not go on routine anticoagulation. So for pulmonary hypertension alone, there's no longer a recommendation for routine anticoagulation. The issue arises to the question that was raised in patients who have other indications. So in our scleroderma pulmonary hypertension population, about a third of those patients will develop irregular heart rhythms, which would require anticoagulation. So that's one population in which we might be a little more concerned. Another population would be patients who had blood clots, either in their legs or their lungs previously. There's mixed data out there about whether scleroderma patients are at higher risk for this compared to other to patients who don't have scleroderma. I'm not sure where I fall on the side of that debate, but in any case, there might be other indications in which you want to have a week might be a little bit long, and you might want to think about a shorter time period if at all possible. But obviously, it would be a conversation that we would have about the relative risk and benefit.
You know, and there are also strategies where we can keep someone anticoagulated but just use different medications. So for example, if somebody was on a blood thinner like Eliquis for an abnormal heartbeat, you could stop that and bridge them on enoxaparin or heparin, and then stop that the day before surgery. So we do have options. That's why we have to all get together and talk before we plan these surgeries. Dr. Boucher.
I was actually just going to pass it to Dr. Whitlow.
Questions? Don't be shy, now's your chance.
I have a question here for Dr. McMahon. Is vagal nerve stimulation being considered as a treatment option?
So absolutely. We are, as you may have remembered from my talk earlier, we are using the device that's the transcutaneous electroacupuncture to stimulate different points in the body that are connected to the vagus nerve. And so there are 2 points that I think you saw in the slide that had stickers on them that were connected to the little devices. One is in the leg and one is in the wrist. The one in the wrist goes, the stimulation goes through the brain and then stimulates the vagus through that point. And that enhances motility.
Okay, we have a couple questions for the whole panel. Thoughts on holistic approach for patients that can't take anti-inflammatories? For example, CBD oil, medical marijuana.
Somebody's going to go first. I'll go first. So I have a fair number of my patients ask about this, and the short answer is, and it sort of begs its own question, there's not a ton of science behind this. I have a few of my patients who tell me that the CBD oil, the cannabidiol, I believe is the long form of that, really does wonders for their comfort, or they've seen an association with improved ulcer healing. The challenge with any of these homeopathic agents, anything that you don't get in the route of a traditional medication, is we don't really know the purity of them. We don't really know the amount of the agent, or even if the agent that you think you're getting is the one that's actually doing the good work for you. So the conversation I normally have with my patients is, what have you used? What has your experience been? What is the good? What is the bad? What is the cost? You know, there are various prices of these things. In general, especially if we're not talking about, we're about to do a surgery or something like that, I tend to be fairly permissive of it, just with the acknowledgement that there isn't science, either good or bad, I don't know, and if for you, the person in front of me, you feel like it's helping, I tend to say, okay, if you feel like it is doing more harm than good and it seems a worthwhile exchange, I tend to say, okay, that seems reasonable. I have some misgivings about medical marijuana just in a general sense because of what we learned about opioids from 20 years ago. Are we just going to turn this into the next thing? I'm hopeful that science will catch up sooner than we make the next medication crisis like we have for the opioid now. But for the topical agents, if an individual patient feels like it's doing them some good and giving them more benefits than side effects, I tend to say, yes, that's okay.
Sherry, can you talk to the effect of placebos on health?
Good question.
Yeah, so I think so CBD and medical marijuana, they both, there's good evidence regarding sleep and pain control and pain management. And again, there's a risk-benefit ratio, since even though medical marijuana is a natural substance, there are still side effects related to cognition, to ability to drive, and to function on a regular basis, so keeping that in mind. There are, like Dr. Lee was just asking about placebo, so placebo is basically your expectations, right? It's an expectation that something will help, and we know that even with medications that are very potent, like antibiotics, there's a placebo effect that's actually triggering in your body the same mechanisms that the medication triggers. So it's not that it's in your head or that you're just imagining that things work. Your body, because you're expecting something, your body mimics in a very real way those same chemicals, the same processes that happen with your with actual medication. And with pain medication, we know that the placebo effect is about between 30 to 40% of the actual effect of the medication is related to our expectations. And we have many, many studies in different populations that show that, and that's great news, because it means that even without medication and the side effects, you can create the benefits through using your mind, through using relaxation techniques, through using guided imagery and self-hypnosis. You can actually change the way your body works in a very real way without using agents that might have negative side effects.
As the resident
How long do you
pulmonologist.
expect that to work?
Well, as long as you might expect it to.
So as the resident pulmonologist on the panel, I must say that smoking marijuana, actually inhaling marijuana, has a different set of risks than the edibles or the oils. And that with the marijuana comes bacteria and fungus that can set up in your lungs. So it is very important to understand that smoking marijuana in any form is not the same as the other forms we're talking about, and can lead to other risks and other complications that we haven't covered here. And smoking is not good, in case
Okay, we have a question for Dr. Hummers. Is spin study data included in precision medicine big data analysis?
So we are collaborating, there's a group of investigators in Canada, and Brad Wigley has been the person who has been interacting the most with regards to spin, so if there's specific questions about spin, and what they're doing. Spin is a multi-center program that's intention ultimately is to look at the effects of some treatments in scleroderma patients that are not necessarily medical treatments, but they are collecting data prospectively from patients in the form of questionnaires and things like that. Right now, that data, even though some of it overlaps with data that we're already collecting, so there are some of those questionnaires that we're collecting that overlap with this. We are collecting some data that is going into our precision medicine initiative. The specifics, there's not a specific collaboration at this point yet with SPIN.
I can just mention a little bit more. So the idea behind this is that a lot of our treatments are disrupted by the fact that it's hard to have you come in every day, to travel hours and hours to see the doctor to get instruction and guidance about what to do. So this group of collaborators that are located in Canada, but have started an international program to do things online. And the first phase of that was to define what the problems are by doing patient interviews and so forth. And the second phase of that is intervention online. So for example, let's say that you have fatigue. Are there things that you can do at home on a regular basis if you're given instruction that you can interact with an expert online and have help day to day? And so they've gone from the last few years of finding out what the problems are and what potential solutions are to now designing online home-based care to help patients not only on the coping side, but also on the functional side, dealing with things. For example, one of the first programs is how do I deal with hand disability in the home program as a home. Like we were talking about, exercises, other things that can be done in the home on a regular basis. I wanted to ask another question of Cheryl, if I could. One of the big problems that I hear a lot of is I have trouble sleeping. And I was wondering whether you could tell us something about the difference between sleep aids and sleep therapy.
So sleep disorders or sleep disturbances, especially insomnia, so difficulty falling asleep, staying asleep, or waking up too early, are pretty common in scleroderma and also common in people who have chronic pain, which is also something that's associated many times with scleroderma. And we know now that sleep aids or medications that help you fall asleep, they're effective. They help you fall asleep usually, but they have a hard time keeping you asleep, and they might leave you drowsy in the morning. And now the guidelines are that the first line of treatment for insomnia is actually not medication. It's a form of psychotherapy, so talk therapy, cognitive behavioral therapy for insomnia. So it's a special kind of treatment that focuses very specifically on your behaviors, on your sleep environment, on your sleep schedule, to help you change those, when you go to sleep, what you do before sleep, what you do in bed, that we've shown in many studies that's very effective, that can actually cure you from insomnia in just a few months. So about 6 to 8 weeks of intervention and when you compare it to medication for insomnia, it's as effective, has less side effects, and has better long-term results. So there's a great behavioral sleep medicine clinic here at Hopkins where we do this type of intervention, CBTI, or cognitive behavioral therapy for insomnia. And it's very effective. I don't think there are any studies in scleroderma specifically. That's a good project to do. But we have a lot of experience with other chronic medical conditions and insomnia, and we've shown that it is very effective. So if you do have difficulty sleeping, then it's something that can be resolved. And when you sleep better, then everything's better, right? You feel better in the morning, pain is less, your mood's better, you can do more things. So it's not something to keep untreated.
Just a comment again from the pulmonary perspective here, because a lot of the sleep interventions tend to be housed in pulmonary. How many people here are getting older? So as you get older, unfortunately, your internal clock changes, and the time you spend in the most restorative phase of sleep gets smaller. Medications which is why, the jokes are as you get older, you start waking up at 5 in the morning, you're eating breakfast at 6 in the morning and dinner at 4, right? So your internal clock gets out of whack as you get more mature. But the medications that you take to help you fall asleep diminish that restorative phase of sleep even more. So anything you take cuts into that, whether that's Benadryl, which I know is popular for helping people fall asleep, or whether it's actually a prescribed medication. So think about that before you start taking pills or continue to take these pills, because it may make you fall asleep, but as was just said, the quality of your sleep is going to be diminished.
Steve, can you comment on this, the new drug that was just approved for the treatment of scleroderma lung disease, and where its place is in management?
I don't know how you feel about it, Fred, because we haven't talked about it, but I will say that I think the study that just came out about ninapib in patients with scleroderma-associated lung disease or fibrosis in their lungs, I don't think it's not a revolutionary finding. Okay, I think that the study had some positive aspects to it, but it's not necessarily something that is going to revolutionize how we treat patients with interstitial lung disease and scleroderma. I do think that there are some positive things that potentially can come out of this, but I caution, anytime there's a new drug that there's a study that's positive, there's a lot of publicity that's given to it, both in the medical side, but also marketing towards patients, and I just caution, I think it deserves a conversation with patients and providers to understand if it's right for you. And I think that's the key thing here. The patient population that was studied, that were enrolled, was kind of a very specific type of patient, so it may not apply to you personally, which is one of the things you have to make sure that the results actually would apply to you. I think there will be more and more studies looking at patients who have scleroderma and interstitial lung disease or have pulmonary hypertension, focusing specifically on that, because I think that there are some exciting possibilities for treatment. But I do think we have to make sure that whatever results come out, that they are relevant to you as an individual.
Laura, you were involved in the research. Can you give a rheumatologist perspective?
Yeah, so I think as a rheumatologist and scleroderma expert, I think any progress in the field of scleroderma is exciting, and a new drug getting approved in scleroderma is certainly a milestone. I agree with Dr. Matai that the effects of this drug were fairly modest, and again, it's not going to be something that is going to replace everything that we're doing necessarily, or at least not until we get longer term data from this. So I certainly am happy to have a drug that maybe have benefit available to us, because the more drugs that we have available to us, the better. I think it's going to take some more real world experience to know how this drug is going to kind of fit into our regimen. So it's going to be learning for us. Certainly in the trial, there was suggestion of, again, modest benefit of this medication.
Thank you.
Have we had a chance to talk a little bit about levothyroxine?
So the question's about linamicin, which is another drug that's in trial. We all have to agree how we're going to pronounce all these names. So this is a medication, somewhat relative to our discussion before, that has been in clinical trials for early diffuse scleroderma, so patients who are in the early phase of disease who have a more widespread skin changes. This drug is produced by a pharmaceutical company that interacts with the cannabinoid receptors, so it is intended to work similarly to how cannabinoids work, how CBD works, but created by a pharmaceutical company known specifically to interact with this receptor. It does not interact with the receptors that are in the brain, so it doesn't have the same effect that, say, smoking marijuana would have in terms of the central nervous system effect. It's meant to work just in the periphery and the other tissues. It has been through what's called a phase 2 clinical trial that has been completed. So that's a somewhat early phase trial that suggested that it possibly has some benefit for patients with early diffuse scleroderma. And so because of that, it has moved on to the more definitive phase 3 trial, and that trial is ongoing now. It's no longer open to enrollment. So it's completed enrollment, and we're following the patients in the trial now. So I think the results are anticipated, my recollection is about mid-2020 from that trial, larger trial.
Yes, sir.
What about studies to actually, find out what the triggers for scleroderma are? Environmental hazards, that to me seems to be one of the bigger things that.
So, we are absolutely convinced that scleroderma is something that you have a susceptibility to acquire from the time that you were born. So this is called a genetic background that sets you up to have an autoimmune disorder. And it may be that genetic background never wakes up, never causes trouble throughout entire life. You live to be 110 years old. Hair grows on the top of your ears and you can't sleep, and all those things happen. And nothing ever wakes up. Then, however, something triggers the disease process. And we think that trigger is more likely to happen in patients that have this autoimmune gene background. And that trigger could be a drug, it could be a toxic material like silica, it could be a bug. And we are pretty convinced from the research that we've done, and we've actually shown very clearly that cancer is a trigger for scleroderma in a certain subset of patients. So we found that patients that had a certain form of scleroderma, that there was a cancer that came within months of the onset of scleroderma. So the immune system was triggered to fight a cancer, and in the process, scleroderma woke up and became active. Very much like when you have the flu, you get sick with fever and rashes and feel sick. When the flu's over, it all quiets down. That sickness is due to the immune system fighting the flu, because it's the viral bug. In scleroderma, the same thing happens, except once that's a patient who has a susceptibility for autoimmunity, once you wake that gene process up, it may not shut down, and it continues to be active and cause long-term problems, because now you're in a different equilibrium. The immune system is woken up by this, either a cancer or bug or silica or one thing in the environment. And our whole approach then is to understand that process. Why does it wake up? Why doesn't it turn off like when you have influenza? Influenza, your immune system turns on, kills the bug, and then turns off. Why in scleroderma does it get turned on and not turn off? And those are very sophisticated studies looking at what the genes are, what turns them on, and how we can regulate them. And what we do now with many of our medications is to kind of calm the immune system down, try to calm the inflammation down. And we put the cap on. What we want to do is put the slam on, to shut the whole thing down. And I want you all to know that the technology is there for us to do that. It's not a pipe dream. And likely something that may happen before I have a lot of hair on the top of my head.
I'm wondering about the hereditary nature of this. What are your thoughts about my children if I have scleroderma?
So it is true that autoimmunity can be inherited. And the scleroderma inheritance is very weak. It's not just one gene, like sickle cell anemia, there's one gene, so it's very likely to be inherited. It's a cluster of genes that work together, and it may be even hundreds of genes that work together. That's why it's been so complex to understand what exactly is triggering it. So there was a study done in about 40 identical twins. They look the same, their gene background is exactly the same, and they looked at one of the pair of the twins had scleroderma. So they asked the question, well, how many of the other identical twins had scleroderma? You would expect every one of them. Yeah. And it was only 4 out of the 40. But the other twin often had signs of autoimmunity if you looked in their blood count. Many of them had a positive ANA. So there was a background of autoimmunity, but they hadn't run into that bug or a chemical or cancer or anything that triggered it. So, and the other thing that's complicated, but there are these things that regulate our genes. So we were born with certain genes, and then depending on what you eat and how you live and who you marry, all those things, there are these regulations that occur in your gene pool, and we call those epigenetic changes, and they regulate the genes in a different way. So be careful who you choose.
Well, I divorce was injured.
Now the questions are starting over.
So what part does stress play in triggering it or aggravating it further?
Well, that's a great question. There are anecdotal, kind of people tend to remember back many times that autoimmune diseases started after a stressful life event for some people. For others, they did not. We know that in general, stress puts more stress on your body, right? So when you're having emotional stress, when a lot of things are happening in your life, you have less resources to manage other parts of your body and your life. And we know from a biological standpoint, stress triggers cortisol secretion, which is our stress hormone, and that can interfere with other of the disease processes. So we want to help, easier said than done, reducing stress in your life by engaging in activities that are enjoyable, by engaging in activities that will reduce stress, like relaxation, meditation, but just having fun is also known to be a great stress reliever. So you don't have to sit in yoga and say all day to be relaxed. You can also do things that you really enjoy, exercise, be with loved ones, hug people. We know that hugs reduce stress. So do things that you enjoy. Those also will change how your body responds to stress, and also improves quality of life. Maybe one of the other physicians here want to talk about the actual stress and biological responses.
Well, I will mention that that kind of acute stress response, if somebody gets placed, and people may notice this, that fight or flight response that we get, that actually causes constriction of blood vessels. So actually a trigger for Raynaud's phenomenon could be kind of a sudden stress. So I don't know if people notice that, but a cold can be a trigger. It creates that same environment, but the fight or flight response can directly impact Raynaud's events.
I have a question about weakness in your legs and your body. Are there any other treatment other than physical therapy and cortisone shots?
That's a great question. When we looked at our cohort, about 20 to 25% of our patients in the scleroderma cohort actually had muscle weakness. I think a lot of the rheumatologists or primary care physicians, we're talking about so much other organ involvement, we may not be able to assess it properly. So that's why one of the questions was, how prevalent is it? And going to your question, absolutely, like Dr. Wigley said, you don't want to, if you don't use your muscles, you will lose it. But beyond physical therapy and using your muscles, we always want to determine what is the reason for your muscle weakness. So there's a lot of many reasons that can cause muscle weakness. One could be because you have severe GI dysmotility and you're having a lot of diarrhea, a lot of weight loss. From a MSK perspective or musculoskeletal perspective, I always want to determine, is it truly coming from the muscle? And we do a comprehensive assessment, including determining what part of the muscle group. Is it more close to your shoulders and your hip girdles, or what we call proximal muscle weakness, which would be different in determining what is causing that muscle weakness, what the etiology is, or is it distal muscle weakness, such as are you having a foot drop, which could be actually a nerve problem, like a nerve entrapment that's causing the muscle weakness. And so that's the first assessment. Number one is, what is the distribution and pattern of weakness you have? And then second, we also couple it with an EMG or electromyography test where we can determine, I know it's, someone's shaking their head, it's like a torture test, but I have done it to myself, and it is painful, but it does give us a lot of information. But I always tell and try to warn my patients about it. Some patients actually, when I've done it on patients, they actually sleep through it. So it really depends on what kind of pain tolerance you have. So that actually tells us the electrical activity of the nerve to the muscle, and is actually the nerve causing the muscle weakness, such as nerve entrapment or a different motor nerve problem that's coming from the spine. And so that tells us what is actually, it's a helpful indicator of what's happening in the muscle. And another technique that we assess the muscle is an imaging technique. The MRI, Dr. Hummer showed a picture of that, of the muscles, gives us an extensive picture to determine is there active inflammation in the muscle, or is there any damage from previous muscle diseases that potentially can cause muscle weakness. So we couple the physician's assessment, the electrophysiologic assessment, and imaging, and then lastly, if we truly believe all of these studies tell us this is a true skeletal muscle problem and not a nerve problem or a joint problem or a muscle significant weight loss contributing to generalized weakness, where all these other tests may be normal, then we may actually pursue a muscle biopsy, which sounds invasive, but very short study where we can actually take a piece of the tissue and then microscopically look at it under the microscope to determine what is the exact reason for the muscle problem or weakness. And then we put that all together and say, how can we treat this if this is truly a skeletal muscle problem? Is it an autoimmune muscle problem? Or actually, I have diagnosed patients with adult onset muscular dystrophy, extremely rare, but that could happen, and we're surprised. We have one patient who had a lipid accumulation problem where they couldn't properly metabolize fat in adulthood, which is seen typically in children, but that was also seen on a muscle biopsy. So it gives us a wealth of information, but absolutely, besides PT, we want to actually get to the source and etiology of what's causing it so we can actually treat it.